question for those who do, I think there was a discussion about doing total hip replacement in acetabular fractures. What are the strategies utilized on the cup side of things? Do you, if it's a both column, do you put the patient prone or lateral, you fix the posterior column, you fix the anterior column, then you do your hip replacement? And if so, what sort of cup do you use? Do you use cemented cup? Do you use multi-hole, trabecular metal? How many screws do you put? This is a big problem, and it's affecting all of us for the next 25 years.
I can repeat the question. If there is a double column fractures, acetabulum fracture, and you intend to do a prosthesis replacement, what to do, right?
I'm using all the time, nearly in every case, a lateral position, because that does not limit myself to go to the anterior and to the posterior. So the second point is, sometimes you need even the lateral position because you have united the ala ossis ED, because there is a fracture as well. You have seen one of the cases where a plate has been used above the acetabulum. The femoral head is advantageous to reconstruct some holes in the acetabulum himself. If there is a hole, I don't trust alone, mostly not alone, to this grafting, but I'm using a cage. That can be a Schneider Burg cage, or which kind of cage. There are many of the market, and I cement the cup to the.
And do you use trabecular metal for this kind of problem? Trabecular never. No. Okay.
Mr. Vexai, okay.
Sometimes the long nails don't respect the anatomy, the femur anatomy. Yes, and this is a problem because the nail is in contact with anterior cortical.
Okay. Please.
Mr. Vexai, you advocated lateral traction in acetabular fractures when there is a medial subluxation or dislocation of the head of the femur. You said lateral traction. I think lateral traction at times works adverse to the direction. The direction of the force, this displaces the anterior wall, and you can see it poroperatively. So I believe, as Judith said, lateral traction should not be given.
Not completely.
Okay, I don't understand that.
It is general, I accept.
In replacement in trochanteric fractures, dislocation and stability is a concern. What is the place of, in your opinion, what is the place of soft tissue reconstruction, soft tissue repair, maybe soft tissue augmentation at the same time, even with additional tissue or additional material?
I all the time try to put together the tissue, I mean the capsule, and it is possible, but not a reconstruction of the muscles of anything. I try to put the stem in the right position, in the higher position of the, and trying to be sure this is the position of the calcar. And then I'm starting using the dual mobility because it's increasing a lot of the stability of these patients. All of these patients are elderly people with problems of follow indications, so they want to be lie lateral side and with the flexion of the hip, and it's a very good solution for me. But I try to suture the capsule.
Thank you.
Okay, you have more time.
Is there any role of osteotomy in trochanteric fracture which are unstable to make them stable and put an osteotomy plate rather than simple DHS or the nail?
I think this kind of solution is today over. Osteotomy is only, in my view, reserved already for femoral neck fractures if the head is not dead, not a necrosis, and is a non-union, then For this indication is osteotomy, in my view, the only one link where the osteotomy has survived.
Osteotomy has no role in trochanteric fracture.
Not in fresh fractures, because in this case I would go with my South American friends, Latin American friends. If I would need a osteotomy to treat a trochanteric fracture, I would prefer to implant a prosthesis. But that is the only one case where I accept a primary endoprosthesis.
I agree. One more question?
Well, I'd like to congratulate the panel. Of course, it is a very controversial topic. And I'd like to know from your experience, when do you operate the patients? In the first 48 hours or more? And the second point is related with the prophylaxis of thromboembolism. Some of these patients, as you know, at least in my experience, some of them, they are taking some medicine, clopidogrel and another drugs that avoid the anesthetists in general. They try to delay the surgery. What do you think about that, this point?
Let me just divide the question. First, trochanteric fracture. When you operate, just the time. In your hospital?
In my hospital, I mean in Colombia, there's a problem with the anesthesiologists and the system, the health system. The best is the first 24 hours, but we'll still operate in some patients in the first week sometimes. I mean,
Okay,
it's very worse.
Then in Argentina, just when operate?
48 hours.
48
In 80% within 24 hours, in 10% within 48 hours, in 10% later.
In the state hospital the same?
Yes.
Yes. And you,
That's the university clinic in
okay,
Vienna.
in Chile?
In Chile, in children, it's very important to operate in the first 48 hours.
Important is, but you can do that?
It's possible, yes.
It's possible.
Yes.
Okay, in Brazil, the state hospital is not possible. You usually have to wait a little bit, sometimes 1 week or more. But in the private, you try to do in the first 24 hours. And the second question, when you begin the prophylaxis, if you don't operate in the first 24 hours, when you begin, what kind of prophylaxis you do? Go this way. No?
In every case, prophylaxis.
DVP.
DVP, low molecular weight heparins. Today, more and more oral. But the question was...
Before the surgery or after the surgery?
Around earliest 12 hours after the surgery.
After the surgery.
12 hours after the surgery. But his question was, what are we doing really with the patient who are anticoagulated and have a trochanteric fracture? Our behavior has been 15 years ago, we are waiting for 4, 5, 6 days.
Now
we have completely stopped, and today the anesthetist comes to us, look, not the first 24 hours, but within the first 48 hours.
If they are using clopidogrel, use this.
Vitamin K,
aspirin,
and fresh
operate in 24 hours.
Yeah.
Okay. I will do the same.
Low weight molecular heparin 6 hours until the surgery and 6 hours after the surgery.
It's the same answer, and also with the patient with treatment of TBP before the fracture, we use the same vitamin K and try to operate in the first 24 hours.
I understand everybody can operate immediately, no problem with anticoagulant before the surgery, but I ask now after the surgery, if it was oral or not, and when it begin.
Now we are using enoxaparin, subcutaneous enoxaparin.
12 hours after the surgery?
6 hours.
6 hours.
Franco, I want to know if you have experience with the ácido tranexánico.
Okay. Can you talk?
That was our classical prophylaxis.
In Brazil, they call transamin, ácido tranexânico.
That was our classical prophylaxis 20 years ago. Then we have given up because the numbers of thrombosis in a huge number of cases. We have around 600 trochanteric fractures a year. We have seen that acetylsalicylic acid does not work enough. So my advice would be today that it's very good to prevent perhaps cardiac attacks and so on, but not for DVT prophylaxis.
But tranexamic acid is for avoiding big hematomas. And I think the patient with fractures goes for higher level of the TVP, but in patient with the arthrosis or a hip replacement, normally hip replacement, we are using in all the patients tranexamic acid to avoid hematomas, and we don't have any problem with thrombosis.
I would like to ask the audience, who are using the tranexamic? Okay? You have any complication? I use no complication, less transfusion. I think for a while it's good.
What are you doing if a revision is needed in the same patient? Then they are bleeding. You can stop low molecular heparins, but you can't stop.
But I don't use, I use tranexamic local, not local. I use local. Okay.
I use intravenous.
No, intraoperative. I'm afraid about that. Okay. And about, no questions? No questions, no time. Please, as a president of Latin American Orthopedic Society, we would like to say thank you for everybody. Have a good time.